everyone, and welcome to the Parkinson's Foundation's Wellness Wednesdays webinar. Thank you for joining us. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made today's programming possible. Thank you, Light of Day, for your support in the Parkinson's Foundation's mission. When most people think of Parkinson's disease, they often picture tremors or stiffness, but there's much more to the experience than meets the eye. Non-motor or non-movement symptoms such as sleep disturbances, mood changes, fatigue, and cognitive challenges can significantly impact our quality of life, often even more than the motor or the movement symptoms. We'll explore the non-movement symptoms of Parkinson's today, and we'll learn how to recognize, how to manage, and how to talk with your care team about these often overlooked aspects of Parkinson's disease. Leading the conversation today is neurologist and movement disorder specialist, Dr. Mary Feldman. Dr. Mary Feldman is the co-director of the Parkinson's Disease Center of Excellence in Movement Disorders Clinic at Dartmouth and also serves as director of the Neurology Residency Program. She completed her neurology residency at UPMC and a Movement Disorders Fellowship at the Cleveland Clinic, where she received the Excellence in Research Award. Dr. Feldman has led programs in movement disorders and stroke and is actively involved in clinical research on Parkinson's, including deep brain stimulation, exercise, and non-motor symptoms. She is a member of both the International Parkinson's and Movement Disorder Society and the American Academy of Neurology. Dr. Feldman, thank you so much for joining us today.
Thank you very much for having me. I appreciate it. Okay, so I'll share my screen and presentation with everybody. Okay, so I'm very pleased to present the Parkinson's we cannot see, so the non-motor aspects of Parkinson's disease. Yes, the non-motor symptoms of Parkinson's are often much more prevalent than the motor symptoms and sometimes really affect quality of life in a much more impactful way. So this is sort of a bird's eye view of the non-motor symptoms. So I'll be really exploring everything in the next 45 minutes or so. So touching upon everything, but not going into anything very deeply. But I wanted to talk a little bit about the history of Parkinson's because Dr. James Parkinson was the first person to really describe Parkinson's disease. And he wrote a very eloquent essay on the shaking palsy where he described Parkinson's disease. And he talked about the involuntary tremulous motion of patients. And of course, he talked about the motor symptoms of Parkinson's. So the bending movement of the trunk, the shuffling gait. But he also, very interestingly, also talked about the non-motor symptoms, which was quite astute of him to be able to recognize that, over 100 years ago. Um, so, so I'm sorry, 200 years ago. So he mentioned that there were sleep disturbances, constipation, some slurred speech, even difficulty swallowing, some excessive saliva, even urinary problems, and even sleepiness, and even some problems with the thought processes. So it was quite interesting that he was able to pick this up when he first described patients with Parkinson's disease. So even though Dr. Parkinson described this in his essay over 200 years ago, we know that the non-motor symptoms of Parkinson's disease are still greatly under-recognized. So according to several research articles, we know that neurologists fail to identify non-motor symptoms in greater than 50% of new consultations, which is striking. That neurologists who are supposed to be experts at picking these problems up in patients fail to identify these problems. So part of this could be that perhaps the right questions are not being asked. Part of this is that patients really do not know, what type of symptoms to even bring up to their neurologist. It's hard to think about when you're going to see a neurologist for a consultation, about gait difficulty or balance difficulty or talking about your tremor, that perhaps urinary symptoms might be connected in some way, or perhaps bladder symptoms might be connected in some way, or excessive sleepiness. So it's very important to be seeing the right person for your symptoms. So that's why it is recommended to see a movement disorders neurologist if at all possible and if available, because we do query about very specific symptoms linked to Parkinson's disease. So that is important. And we know that as Parkinson's does advance, the prevalence of non-motor symptoms also advances. So this is striking. You could see that the symptoms of non-motor symptoms are quite high. And actually, as Parkinson's advances, the non-motor symptoms predominate at 15 years through the disease. So you could see that fatigue is greater than 50%. Sleep disorders is hugely common, 75 to 95%. Hallucinations in 50% of patients. Cognitive decline, unfortunately, in about 84% of people. Anosmia or hyposmia, this means lack of sense of smell or difficulty with sense of smell in almost all patients. And of course, anxiety and depression in about half or even more than half of patients. Difficulty controlling blood pressure regulation, urinary incontinence. So these all cause a substantial impact to quality of life of patients. And as time goes along with the disease, these do increase in prevalence. We know that the non-motor symptoms are associated with, increased morbidity and nursing home placement, unfortunately. So this is very important to address these symptoms with your neurologist. These things could also lead to falls and, even early death. So extremely important to be able to address these. So non-motor symptoms do decrease the quality of life. And any of you that are experiencing these, you certainly will know that they could have a great impact on the quality of life. And research shows that they could have a greater effect on the health-related quality of life compared to even the burden of motor symptoms. Um, and I know that even when I see my own patients, a lot of our, time talking together really is predominated by talking about the motor symptom or the non-motor symptoms rather than motor symptoms. So this indeed is true. So uh, the diagnostic criteria, according to the brain bank criteria, which is sort of the criteria that all movement disorder specialists used up until 2015, included diagnosing a patient with Parkinson's with bradykinesia, that means slowness of movement, and at least one other symptom. So, and at least rigidity, which means stiffness of muscles, and a resting tremor on one side of the body, and postural instability. So, slowness of movement and at least one of those other things. So, stiffness, resting tremor, or postural instability. And the postural instability cannot be due to any other reason. So, we have to rule out other reasons why people may be having other balance difficulties. So we rule out other red flags. We rule out other things that could be mimicking these symptoms. We rule out other Parkinson's plus disorders. Um, but we know that this is simply the tip of the iceberg. So Parkinson's is so much more than the motor symptoms. So there are so many other parts of the brain and the spinal cord that are affected with changes secondary to Parkinson's disease. So research shows that as Parkinson's advances, there are changes that are widespread throughout the entire body. So the Movement Disorder Society actually revised the criteria for the diagnosis of Parkinson's, and this was validated in 2018. So the motor features, of course, are the core of the diagnosis of Parkinson's. So we look for the slowness of movement and then one of those other core features, so rigidity or the resting tremor or postural instability. But non-motor features are now required to be present in the first 5 years. And prodromal features are also supportive. And prodromal features, which I'll go into a little bit on some of the upcoming slides. So we look for impairment of the sense of smell. So that demonstrates some sort of lack of sense of smell or REM behavior sleep disorder. So we're looking for signs of premotor Parkinson's disease as well. So we know that the premotor symptoms can diagnose could predate a diagnosis of Parkinson's disease by years. So REM behavior sleep disorder, constipation, olfactory dysfunction, or depression could occur even decades before the onset of Parkinson's disease. So these are considered the premotor symptoms of Parkinson's disease. So we know that there is significant pathology in the brain that occurs prior to the motor symptoms occurring. So this is sort of a conceptual diagram, and you could see the red line. You could see the dopaminergic neurons as they start to sort of degenerate in the brain. There's a presymptomatic phase where patients really don't feel any symptoms whatsoever. But then as the dopamine neurons hit a critical area, then patients start to experience some sleep dysfunction, some lack of sense of smell. They could experience some depression, and they could experience some autonomic symptoms like constipation. And these are the very early non-motor symptoms or the pre-symptomatic phase of Parkinson's disease, which could be years before the actual motor diagnosis. We know that by the time that perhaps as much as 80% of the neurons are lost, so the dopaminergic neurons in the substantia nigra, that patients start to experience the motor symptoms of Parkinson's. And that's often where patients are then seeing a neurologist for their symptoms. So we know that the very early signs of the motor issues of Parkinson's disease, so Parkinson starts on one side of the body, often with a lack of arm swing. So that's some slowness of movement or rigidity on one side of the body. Often patients could be feeling pain in one shoulder or frozen shoulder related to the lack of movement on one side. Patients could experience some small handwriting or micrographia, and that's related to the bradykinesia that they're experiencing, some decreased facial expression, and we call that hypomimia or softer speech. We call that hypophonia. And as Parkinson's advances, you often hear of patients having fluctuations. So motor fluctuations, freezing of gait, dyskinesia and wearing off, as well as falls. So symptoms are getting quite a bit worse as there's less dopaminergic reserve and there's more neurodegeneration. And as there are these motor fluctuations in Parkinson's disease, there are also non-motor fluctuations in Parkinson's disease. Non-motor fluctuations are present in 100% of patients in Parkinson's patients that have motor fluctuations, and they can be more troublesome and disabling than motor disturbances. So the majority of non-motor symptoms become worse in the off state. So this is a very important slide because a lot of patients, really can't put their finger on why they're feeling so awful, and it's related to, anxiety or shortness of breath or irritability, and it's related to their medication fluctuations. So if you're having motor fluctuations, you 100% are having non-motor fluctuations as well. So non-motor fluctuations in Parkinson's disease. So in order of the most common, so patients could have anxiety, number one. So when your medications are wearing off, you could feel very anxious. until you get the next dose in. Patients could have drenching sweat related to not having medications or being in the off state. They could have slowness of thinking, excessive fatigue, akathisia, and that's a term that means essentially that it's extremely difficult to sit still, and you feel almost like crawling out of your skin. Patients could feel very irritable, or they even could have hallucinations related to being off. Um, so these symptoms could be related to being on or off. So fluctuations could be also when you're peaking with medications. So akathisia could be when your medicines are also peaking too high, irritability when your medications are peaking too high, or hallucinations when your medications are peaking too high. So the best thing to do is to keep a journal um, and to really try to pin down, how are you feeling? When did you take your medications? Um, what was your dose and exactly what is going on so that your doctor could adjust your medications most appropriately. So the information that's needed to make decisions regarding therapy for non-motor symptoms and fluctuations. So you'll want to know medication schedule, your response to medications, side effects noted from your medications. What were you doing in the day? What was your schedule? Did you have protein around the time of your medications? How were you sleeping? And then emotional state and any history of response to meds in the past. So all of this is extremely important. It's very good information so that your doctor could appropriately adjust your medications based on those non-motor fluctuations. So I am going to give you a brief overview of the categories and non-motor symptoms in Parkinson's disease. So we will review the mood and neuropsychiatric symptoms, autonomic symptoms, sleep symptoms, and some other symptoms of Parkinson's disease. So as far as the neuropsychiatric symptoms in Parkinson's, they include depression, anxiety, apathy. Apathy is a feeling like you don't want to do anything. Psychosis includes hallucinations or delusions, like abnormal thinking or abnormal thoughts, and cognitive impairment. So this could range from mild cognitive impairment to frank dementia. And you could have non-motor fluctuations related to all of these symptoms. And you could see the prevalence of all of these symptoms. Um, and they're very common to have at any point within Parkinson's disease. And even if you've never had depression or anxiety or any of these symptoms before in your life, you may suddenly find yourself experiencing these symptoms. And the reason why, and I just put this up for illustrative purposes. There are a great deal of changes that are going on in the brain other than dopaminergic changes, essentially. So there are disruptions of serotonin through the brain. There's also decreased dopamine transporter activity in the frontal lobes. But there essentially are neurochemical changes throughout the entire brain that could impact the way that you're feeling. So depression in 50% of people. So, so how do we manage depression? So I am going to very briefly talk about this because this is a very individualized approach, and management really is going to depend on you as a person and your plan with your own neurologist. So it's different for everyone. It depends on your own, list of medications. It depends on your life. It depends on, um, what you want to do as far as do you want to take medications for depression? Would you rather just sort of talk therapy, or would you rather take a more natural approach? And how severe is the depression too? So some people have very severe depression and there's no way that they could get around to, taking medications for it. And, other patients, it's very appropriate to try some more conservative management to start with, like cognitive behavioral therapy or exercise to start with. So there are multiple medications that are recommended for depression. So we often try SSRIs or SNRIs. There are also, some psychiatrists that try tricyclic antidepressants at varying strengths. Um, and I also have a number of patients that have therapists, and they find that talk therapy is very helpful. And I have many patients that find exercise is extremely helpful for the management of depression and just staying social. Support groups are helpful, and staying involved with other people, especially people that know what you're going through, and having a good support system. So anxiety, again, this is a very real neurochemical thing, due to very neurochemical changes that are occurring in the brain throughout the brain due to Parkinson's disease. So we know that there are changes related to serotonin and norepinephrine, as well as dopamine through the brain. And because of this, up to 60% of people could experience very significant anxiety related to Parkinson's disease. So patients could experience very significant anxiety related to ons and offs. So we have to, determine whether it's an off phenomenon and adjust medications accordingly. And this is where a journal is extremely helpful. And, we could either do non-pharmacological intervention or medication intervention. So adjusting dopaminergic therapy, or trying sometimes an antidepressant, or doing some sort of talk therapy. And there's been some trials on transcranial magnetic stimulation for this as well. So on to psychosis. So psychosis usually occurs later in the course of Parkinson's. If it occurs very early, we become concerned that this is perhaps not idiopathic Parkinson's disease, but could be Lewy body dementia instead. So the most common manifestations are visual hallucinations, and they could occur in about 40% of Parkinson's cases. So the spectrum is just some people see, shadows in the corner of their vision. Sometimes people feel like they have someone standing in the room next to them. They're called presence hallucinations. Um, Sometimes there are very well-formed visual hallucinations. Um, or sometimes people have very abnormal thoughts or thinking, which are called delusions. So it's important to definitely let your doctor know if you're experiencing these. There are ways to mitigate these, and ways, you know, really, really to get rid of them. They could be dangerous. I've had, many scary situations with my patients. So it's definitely worth a conversation. So, and it's the strongest predictor of skilled nursing facility placement, and associated with a higher mortality in Parkinson's patients. So this is something you will want to address with your neurologist. So what we usually do as movement physicians, we rule out an underlying medical condition or a pharmacological trigger that may be causing the hallucinations or delusions, especially if the symptoms were abrupt. So that would be very important to do. So sometimes we check some lab work. We see if there were any new medications that may have been causing the problem. So occasionally we reduce dopaminergic medications. Um, and sometimes we're not able to do that, or sometimes the hallucinations are from the disease itself. And sometimes antipsychotics may be useful, or a referral to psychiatry. And there are many medications which we use. So we use sometimes quetiapine, clozaril, clozapine, or pimavanserin for this. As far as cognitive dysfunction in Parkinson's, so mild cognitive impairment is cognitive decline that is not normal for age, but patients can still carry on normal functional activities. So we know that approximately 27% of Parkinson's patients have this. And this increases the risk for the development of dementia. But these patients don't yet have dementia. We know that mild cognitive impairment can be present in the early stages of Parkinson's disease, and it's more common than having executive dysfunction. It's different than Parkinson's disease dementia. Parkinson's disease dementia is also very common, about 31% of people. And Parkinson's disease dementia, you have to have domains that impair your daily life. And it is very common, unfortunately, after you have Parkinson's disease, after a decade or two, up to 75 to 80% of all people do experience this. There are medications that we do use depending on the patient. And this is, again, a personal conversation with your neurologist. But these are common medications which we do use. So rivastigmine, you may have heard of this, or donepezil or galantamine. And some people use memantine as well. Moving on to dysautonomia and Parkinson's disease. So briefly, I'll be touching upon orthostatic hypotension, gastroparesis, constipation, and bladder incontinence. So orthostatic hypotension essentially means your blood pressure is dropping abnormally. There's very certain criteria that we use as neurologists. So there has to be a fall of at least 20 millimeters of mercury in the systolic, or 10 millimeters of mercury in the diastolic blood pressure within 3 minutes of standing. It's a very technical standard, but essentially patients feel lightheaded, they feel really dizzy, they could pass out, they could have blurred vision. They could feel this coat hanger headache where they feel this really strange sensation in sort of their upper back. So how do we manage this? So the biggest thing is you would talk to your doctor about these symptoms, and your doctor may reduce or remove medications that may cause orthostatic hypotension, but it may be very hard to do that. We always educate our patients to stand up very slowly, to try to use compression stockings, to regularly exercise, to avoid alcohol. It may be helpful to sleep with the head of the bed a little bit elevated, to drink plenty of water. Sometimes adding a little bit of salt would be appropriate depending on the patient and if it's safe, depending on your medical conditions. We do recommend some small and more frequent meals rather than big meals, to reduce carbohydrates and and caffeine after meals. And there are certain medications which may be appropriate after discussion with your neurologist, and they are listed there as well. Gastroparesis. So this means basically the stomach is not working well. So things are really slowing down. Things are not digesting well. So patients could feel like they're full early. They feel this really full sensation in their stomach. They can feel like their abdomen is a little bit distended, or feel bloated, or even nauseous, or feel vomiting. Sometimes this requires a consult with a GI specialist to fully diagnose this. And sometimes medications need to be prescribed also by a GI specialist. But small, frequent meals would be the first initial step. Constipation is an extremely common symptom of Parkinson's disease. It's one of the most common and distressing GI symptoms. And as I mentioned before, this is a premotor symptom of Parkinson's disease. So it can predate Parkinson's by a decade or even two in some patients. So this is a very common conversation that I have with many of my patients. And 59% of all Parkinson's patients meets the Rome criteria, meaning less than 3 bowel movements per week. And they feel like they can't completely empty when they have a bowel movement. They feel like they're straining or have very hard stools. There are many different types of constipation in Parkinson's disease. So it's extremely important to, try to determine what kind of Parkinson's constipation that you actually have so that it could be treated most effectively. Often this does require a GI consultation and GI workup. There could be slow transit constipation, meaning things are just moving a bit slower, or sometimes the muscles aren't working properly. So there's dyssynergia. So the muscles aren't pushing appropriately, and that occurs in up to 60% of Parkinson's cases. So sometimes the treatment for that is more physical therapy or Botox or some sort of biofeedback, which could help those patients. Also, there's other lifestyle modifications which can be done as an initial first step. So increasing fluids and fiber intake is extremely helpful. Exercising daily will also get your gut moving a little bit smoother. There is some newer research on probiotics. We know that probiotics are likely helpful. We just don't know exactly which one to sort of recommend. So there's more research being done on that topic, and likely prebiotic fiber is helpful. And the Movement Disorder Society does recommend Miralax as an osmotic laxative to sort of get things moving. And there are other medications which I have listed here, which often are prescribed depending on your situation and a conversation with your physician or GI specialist, depending on what type of constipation that you have been diagnosed with. There are also urologic manifestations in Parkinson's disease, so that we know that bladder issues occur in about 40% of Parkinson's patients. And these issues could include urinating frequently at night, so getting up frequently to void during the nighttime, or during the daytime, just feeling like you have to empty your bladder frequently, or feeling a urge to go, or urge incontinence. So actually having incontinence of the bladder. So as far as awakening at night, we know that this occurs in 60% of all Parkinson's cases, and it's associated with very poor sleep. We know that there is an increased risk of falls as well, because as patients are waking up in the middle of the night, they often, it's dark in the room or they're feeling more off in the middle of the night. So this is associated with more problems in our Parkinson's patients. So hip fractures, other injuries. Um, so this is very important to address. So this could be because of bladder overactivity, or there could be polyuria. So this is important to discuss with your physician, your movement specialist, your primary care physician, and to possibly get a referral to urology if that's appropriate. So often a urology referral is needed to perform something called urodynamics. So they perform tests on the bladder to see if your bladder is emptying in a proper way, or if you're still retaining urine, or sometimes there could be weak pelvic muscles, or sometimes there's prostate disease in men that is actually causing the issue. So occasionally, we could do some behavioral interventions to help the issue. So we always recommend sort of minimizing fluids before sleep. So sometimes, drink fluids up until about 6 p.m. and then stop around 6 p.m. and see if that might help. If you're taking a diuretic, take them in the morning, not close to bedtime if that's possible. And then treat constipation, because if you have excess pressure on the bladder from stool, that could also make you feel like you have to use the restroom. It's also important to sort of elevate your legs in the daytime, if at all possible, um, so that if you have edema, it's not, draining essentially into the kidneys and the bladder as you lay down to sleep at night. And wear compression stockings in the daytime for the similar reason. Detrusor hyperreflexia is more common in Parkinson's disease as opposed to nocturnal polyuria. which is related to having high blood pressure. So detrusor hyperreflexia means that the bladder is just hyperactive, essentially, and it's just the muscle just is very, very hyperactive. So there are certain medicines to treat the bladder hyperactivity, and they are listed here. These might be familiar to you. And some neurologists do Botox on the bladder, so botulinum toxin injections, which have to be done every 3 months. And this helps relax the bladder. And these can be very effective, but of course, carry their own set of side effects. Um, So moving on to sleep disorders and Parkinson's disease. I know I'm moving fast. There are many, many symptoms to cover as far as non-motor symptoms. So daytime sleepiness, we call this excessive daytime somnolence. And as far as nighttime symptoms, we deal with insomnia, REM behavior sleep disorder, restless legs disorder, and periodic limb disorder, which could all disrupt the nighttime sleep. So, starting with uh, REM behavior sleep disorder. So, REM behavior sleep disorder. Um, so, this is, we call it a parasomnia. So, it's characterized by repeated episodes of REM sleep related vocalizations or complex motor behaviors. So, this is when you're in the dreaming state and suddenly um, you act out your dreams, you yell or move or kick or scream. So, essentially, you are dreaming but not paralyzed during the dreaming state. So it occurs in about 50% of all Parkinson's patients, but it also occurs as a premotor Parkinson's symptom as well. It is the strongest premotor symptom of Parkinson's disease. So more than 90% of patients that have this will develop Parkinson's or another synucleinopathy, which means Lewy body disease or multiple system atrophy. So, as far as the behaviors that people could have, so usually these, the kicking, the yelling, the punching could occur about 2 hours or so after the sleep onset. It's usually violent. Usually patients are dreaming that they're being attacked or chased, and a lot of sleep injury could occur. So, we usually try to ask questions about this and treat this if possible. Um, we educate the patient and bed partner on these symptoms, and as neurologists, we reduce drugs that can worsen or precipitate REM behavior sleep disorder. So some antidepressants can worsen this, and some antipsychotics could worsen this. We also try to reduce things around the bed that could injure the patient. So there's some sharp edges, like on nightstands or some other sharp objects, which we ask patients to move away. Um, and we often start melatonin or a little bit of clonazepam to try to help mitigate this sort of excessive movement in patients' sleep because of the risk of injury. As far as insomnia, this is difficulty initiating sleep or maintaining sleep, or waking up earlier than desired. Sleep fragmentation is extremely common in Parkinson's disease. It occurs in 80% of all Parkinson's cases. So patients are very tired often. This could be because of a number of things. So because of motor causes, so people could feel some muscle tightness or dystonia, meaning um, some cramping or other discomfort while they're sleeping, rigidity or difficulty rolling around in bed. They can feel restless, restless legs, or tremor. So it's very important to try to determine if it is because of a motor symptom that you cannot sleep. There are also non-motor causes. So are you getting up frequently to urinate? Are you seeing things, having hallucinations? Do you feel really depressed or anxious? Are you having pain that is keeping you awake? And we know that there's also neurodegeneration that occurs in the sleep regulatory centers of the brain. And I listed them here, but sleep disorders are extremely common in Parkinson's patients. So what do we do about that? So as far as if it's a motor related symptom, we optimize dopaminergic therapy. So this is again a conversation between you and your neurologist. It's very important to keep a journal of your symptoms, what's going on, how are you feeling, when was your last dose of medication, and what could be done, um, to make you feel better, essentially. And your doctor can help you adjust your medicine. So often, a dose of carbidopa, levodopa controlled release at bedtime does the trick. But sometimes some other dopaminergic therapy um, needs to be added to help your symptoms. If it's anxiety, depression, or another non-motor symptom, make sure that you're getting adequate light exposure in the daytime. Um, that does help with the circadian rhythm. Make sure that you're exercising appropriately. That also helps, to make sure that you're actually tired when it's time to sleep. Um, do not nap during the day if at all possible. Um, this is a very common thing that I see my patients do, and it's a hard cycle to break because people are so tired, because they're not sleeping well, they nap, and if you're napping excessively, you're not tired when it comes time to sleep at night. And sometimes cognitive behavioral therapy does help if you're very depressed. Other sleep disorders, so REM behavior sleep disorder, if you're moving around or acting out your dreams, there are treatments for that. If it's restless leg syndrome, there are treatments for that. We treat sleep apnea, obstructive sleep apnea. So often we're doing sleep studies. Um, and sometimes a CPAP is appropriate. So there's many different things we need to evaluate when looking at sleep disorders. It becomes quite complex. So I know that was a whirlwind. Um, and just kind of a bird's eye view of the non-motor symptoms of Parkinson's disease. And this was meant to be an overview of everything. So in conclusion, the non-motor symptoms of Parkinson's disease are extremely complex, but most Parkinson's patients, so 98%, have at least one non-motor symptom. And again, as the disease progresses, the non-motor symptoms become more prevalent and more troublesome. And the non-motor symptoms require recognition by neurologists and open dialogue with patients. Um, they involve consideration of the whole person and the whole picture, and consideration of medicinal and non-medicinal strategies. And I am happy to have a discussion about this.
Thank you, Dr. Feldman. I really appreciate the way that you offered an umbrella overview of the non-motor symptoms of Parkinson's. And for everyone here who's joining us, I recognize, as Dr. Feldman highlighted, there's a lot of depth when it comes to understanding the non-motor symptoms of Parkinson's. And the intention of this webinar was to offer you an introduction to what those may be. The Parkinson's Foundation has hosted many, many webinars, has all kinds of resources that allows us to go deeper into these very specific non-motor symptoms. So for the sake of today's presentation and our intention for our webinar, I'm going to keep the questions pretty general so that we can keep the conversation more applicable to a wider audience, and invite you to explore those resources that go much deeper into the very specific non-motor symptoms that are related to Parkinson's. The first question, Dr. Feldman, I'd love to ask, we've gotten several people as you were going through the presentation to provide clarity on what off means. Can you describe what it means to be off? What is the vernacular, the language there? What does it mean to experience off symptoms?
Sure. So off means your medications aren't working well. So off time is the time in between your medications where you just don't feel like you could move well again, your tremor returns, or whatever your baseline Parkinson's symptoms were, rigidity returns or slowness of movement returns, and you just um, don't feel the medications working.
And so does that work with using the opposite of experiencing on times?
Yes, so on time is where you feel like you're having, great movement, your medications are working very well for you, and, things are going quite well.
Thanks for clarifying that. I hope that was helpful for all of you who are just learning some of this really, I would say, foundational language of being in the Parkinson's community. So thank you for offering that, Dr. Feldman. I'm curious. There was one thing I didn't hear mentioned too much in the overview of non-motor symptoms, and one of our participants asked, "Is pain a non-motor symptom of Parkinson's disease?"
Pain is, yes, that is also a non-motor symptom of Parkinson's. There are probably many other things which I did not mention here, just simply for time's sake. But pain, pain is also complex because people could have pain due to the rigidity or dystonia or very physical things, and some people have pain because of their arthritis and other reasons, but some people do have pain that we can't fully explain, which could be a non-motor symptom of Parkinson's disease.
Yeah. Thanks for acknowledging, there's more behind the subject of exploring non-motor symptoms and really harnessing on what we might call the cardinal non-motor symptoms of Parkinson's disease. And I see some people are asking about toe cramping, postnasal drip. So there's blood pressure. There's many things that could potentially be related to our Parkinson's disease that we could talk more about.
Yes, absolutely. Yeah, it's probably every one of those subsections. I could have given each subsection a few hours for
Yeah.
sure.
Yeah, which is why we have these webinars. So if you all just look back at some of the archive videos, you'll see there's very specific webinars and some of these things that you're asking about. So thank you, Dr. Feldman, for acknowledging that there's so much more that we could cover and acknowledging the time that we have to share together. There was one question about the commonality of experiencing non-motor symptoms early on in the Parkinson's disease cycle. Do you have a statistic or kind of an idea of what's experienced with people with Parkinson's for those non-motor symptoms early on in the diagnosis of PD?
So, because now it's part of the diagnostic criteria, um, we think that everyone, if we dig hard enough, everyone has at least one non-motor symptom. So it
Mm-hmm.
could be at least, lack of sense of smell or constipation or, just something.
Mm-hmm.
So again, it's 98% of all people. But it does increase significantly every year as we go along in the disease.
Um, Dr. Google, let's talk about the resource that we all have access to and recognizing that it's very useful, right? Accessibility and offering us some guidance in navigating Parkinson's disease. But one of our community members mentioned that they would like some advice on for a person with Parkinson's on how to communicate about their disease with family members or peers, with people who seem to feel like they know better than them because of Dr. Google. Anything to share to our community member about educating or communicating about their disease to people who are curious?
Yeah, that's a great question. Yeah, because with AI and Google, I mean, yeah, probably you could get a lot of generic information and probably a lot of incorrect information
Mm,
on the internet as well. I find that people come to me and they're actually misinformed by things that they hear online or in chat groups on Facebook, etc. So I think it's important to know or to tell family and friends that everybody's disease course with Parkinson's disease is a very individualized disease course, and there could be no generalizations made. Everybody's very different. Just because one person has a certain symptom doesn't mean another person will have a symptom, or just because your friend falls, it doesn't mean you'll fall, or because somebody has a tremor that this person will have a tremor. So everybody is extremely different and unique. So
mhm.
I think that's very important to know or to convey.
Yeah, I hope that was helpful for you to the person who asked that question. It is a unique journey, and ChatGPT, chat rooms, and Google doesn't have the answers to my specific disease course. And thank you for your curiosity, and I'm consulting with my doctor. um, Common question that's coming here too, and this isn't necessarily non-movement related, and you might correct me, Dr. Feldman, but how common is toe cramping or spasming in the feet in Parkinson's disease? Is that a related symptom to Parkinson's?
It is extremely common. It is very common. I hear that from so many of my patients. It could be from a number of things. So it could be due to a dopaminergic deficiency. So that's number one.
Mm,
So not enough medication, not enough carbidopa, levodopa, or look at your off time. So is it happening between medications? Is it happening during the night? Um, so very important things to look at. Or is it a dystonia? Is it truly a dystonia? It could be just part of the disease. Sometimes we need to do Botox, or add another sort of muscle relaxant or something to help the dystonia. There are other little, tips and tricks I try with my patients to help with cramping. I think I have my own tricks, but I think it's a good conversation to have with your own neurologist
mm,
about that. It's always good to make sure you're hydrated and that you're stretching. And then also you check electrolytes, make sure your electrolytes are good and that you're having your labs checked as well.
mm. Yeah. For people who are not on medication yet, would it be recommended to start medications for cognitive issues? Would starting medications help cognitive challenges?
It depends. So So not always. It really depends on the level of cognitive challenge. We do cognitive testing, and if you're having enough cognitive impairment where you're having domains of your life impaired and you're struggling, then yes, it helps. Um, but if you're having some mild cognitive impairment and you're still able to do everything, then typically no, we recommend exercising. That helps dramatically. It helps mood, but it also helps cognitive reserve.
Um,
And the other thing is really just checking your blood work because sometimes you're deficient in B vitamins, you're deficient in, folate, you could be just vitamin deficient, thyroid could be off, there could be so many other reasons.
mhm,
So it's important just to, connect to your doctor, let them know what's going on. And sometimes there's some underlying reversible causes that could be corrected.
mhm. Yeah. So there's a lot of questions in our chat here about medications, and I'm intentionally not asking them because this is a program about non-motor symptoms and movements. We have lots of resources on medications specifically. And so I'd like to turn towards one of the questions that's returning to the cognitive changes, hallucinations. And there's a community member who's curious about vivid hallucinations during the daytime. Do you know that if this is a common phenomenon in people with Parkinson's?
It should not occur in early Parkinson's disease. If it does, we would be a little bit more concerned again about Lewy body disease if it's
Mhm,
occurring early on in the disease. You could have vivid hallucinations in Parkinson's, but usually later on. Um, and again, we would do, all of that regular workup that I mentioned. We would make sure that there's no exacerbating medications, that there's no underlying infection. We would try adjusting dopaminergic medications. We would check memory, make sure that the patient doesn't have dementia, and then perhaps add a medication to help mitigate the hallucinations.
mm. Is there anything else that we could do to slow the progression of neuropathy?
Of neuropathy,
Hmm.
it depends. So neuropathy has so many causes, and Parkinson's itself doesn't cause neuropathy. So neuropathy, it could be, due to vitamin deficiencies. It could be idiopathic, meaning we don't know what it causes. It could be genetic.
Hmm.
Um, it could be from diabetes. It could be due to alcoholism. So there could be so many reasons. So it's important again to for your doctor to do a thorough exam to figure out why do you have the neuropathy. Sometimes we do it's called an EMG, a nerve conduction study, to try to determine the cause. Is it small fiber or large fiber? And then really dig into, could we reverse the underlying issue?
Mhm. I'm curious, this isn't the first time that I've heard an expert encourage the community to have a Parkinson's diary. And as a provider, how often do you see your patients come in with a diary?
I see it pretty often. We actually encourage it if a patient calls and they're having symptoms and we just can't pinpoint exactly what's going on, it seems a little vague. We actually um, mail them either on electronically or in the mail um, a diary to complete for us. So a 2-week diary, and they complete it. It's extremely helpful.
Mm,
So we do encourage that. And some patients just self-complete a diary. It's
yeah.
usually people that are naturally quite organized, but they come in with it.
Yeah.
Um, but it's a very, very helpful tool for us to determine how to appropriately adjust medications based on symptoms.
Yeah. Do you feel the diary also might provide, self-awareness, having the intention of this is something I'm providing for my doctor, but really spending some time and being like, oh, recognizing that these patterns I'm using, I didn't exercise this day, or I did eat protein when I took carbidopa levodopa. Do you find that self-awareness is also useful?
Yes, absolutely. I have people say that all the time. I just had this conversation with somebody yesterday. They didn't realize that it was this problem, causing these symptoms until they did the diary.
Mm,
So it does, it makes you really reflect a bit more than you would. Sometimes you're busy, you're not paying attention. So it's very, very helpful to do.
that's great. Dr. Feldman, thank you for your time. And just as we reach the top of the hour and closing for our program today, any final words to share specifically on understanding non-motor symptoms of Parkinson's with our community?
I would just say that it's important to have an open conversation with your neurologist. Definitely take notes, write everything down. We like that; it's helpful. Yes, keep diaries and keep exercising.
Keep exercising. It's the one thing we know that slows the progression of Parkinson's disease. Thank you so much, Dr. Feldman, and to everyone who was able to join us today. Really appreciate the way that you showed up for yourself in community. And the many questions that you all asked. Thank you so much for your curiosity and being vulnerable to ask these questions that mean so much to you, and recognizing that this is a very large subject, and with only 60 minutes to share with you all, there's a lot more to move into with past webinars and future webinars. So thank you all for tuning in today. Um, Before we close, I'd like to remind you about our other PD Health at Home virtual programs. Each week, we offer sessions tailored to support people with Parkinson's and their care partners, including Mindfulness Mondays, more Wellness Wednesdays, Fitness Fridays, expert briefings, and our Spanish language series, Y Salud en Casa. Please be sure to visit our website to see what's coming up and what we've already done in the past. Those recorded webinars have been really helpful for so many, so don't hesitate to tap into that curiosity. And before we wrap up, just one last favor to ask of you, knowing that your feedback is what drives the programs of the Parkinson's Foundation, and it's essential for shaping how we deliver education and resources to you. So as the webinar concludes, a survey will pop up on your screen. Just take a moment to share your thoughts and let us know what topics you'd like to see in future sessions. And again, if we didn't get to your question, or if new ones come up as you process and integrate this information, we're here to help. You can visit our website at parkinson.org. You can call our helpline at 1-800-4PD-INFO, or email us at helpline@parkinson.org. Thanks so much for joining us today. And Dr. Feldman, thank you for the work that you do.
Thank you.